Good evening. My name is Christian Rowan and I'm your Master of Ceremonies for the evening. I'd like to acknowledge the traditional owners of the land on which we meet, the Turrbal people, and pay my respects to their elders both past and present. Welcome to our annual Q&A event with Tony Jones. This event provides a platform to celebrate and showcase the specialist talent at the Wesley Hospital and also at St Andrew's War Memorial Hospital. Throughout the day program today, we've had GPs from across southeast Queensland participate in interactive educational workshops accredited by the RACGP with a special focus on minimally invasive surgery. And tonight we welcome everyone here for the evening part of the program. I'd like to extend a special welcome to all the general practitioners here tonight and also our visiting medical practitioners from the Wesley Hospital and St Andrew's War Memorial Hospital. It is indeed a unique opportunity to have all of our GPs here with our specialists together in such a vibrant and collegial environment. I'd also like to welcome and acknowledge our sponsors for the evening because without their support we wouldn't be able to put an event on like this. Our bronze sponsors include QML Pathology and Queensland Diagnostic Imaging. Our silver sponsor is Device Technologies, and our gold sponsor for this evening is Medtronic. Medtronic was founded in 1949, and since developing the first wearable external cardiac pacemaker in 1957 and manufacturing the first reliable long-term implantable pacing system in 1960, Medtronic has been the world's leading producer of pacing technology. And today, Medtronic is the world's leading medical technology company providing lifelong solutions for people with many chronic diseases. In fact, each year, 5 million patients benefit from Medtronic's technology through treatments of conditions such as diabetes, heart disease, neurological disorders, and vascular illnesses. And in fact, my wife recently had a Medtronic insulin pump applied, and that's going very successfully. I'd also like the audience to join me in thanking our sponsors for this evening. So if we could thank our sponsors, that'd be great. And I'd also like to welcome our partners in medical education, the AMA, and as the current president of AMA Queensland, I'm delighted that the AMA has supported tonight. Tonight we kick off the program with the popular and critically acclaimed ABC's Q&A, where we'll be asking the hard questions on the issues of palliative care. But before we do that, a little bit of housekeeping. There will be no food or beverage service during the Q&A, so hopefully everyone's been replenished till now. And tea and coffee will be served after the Q&A is concluded. Can I please ask people to turn their mobile phones to silent? It's essential that we don't have any interruptions throughout this evening's show. So to get things underway tonight, I'd now like to welcome the panel to the stage, and I'll be introducing each member after they're up on the stage. So if we could welcome out the panel to the stage.
David.
Before introducing the panel, I'd also like to extend an apology from one of our panellists, Cheryl Royal, who, due to a family emergency, cannot be with us tonight. And certainly our thoughts are with Cheryl and Richard and her family at this difficult time. I'll start with Associate Professor Lewis Prado down the end there. He joined the Wesley in 2004 as the Director of Medical Services, and in his role he's responsible for the accreditation of visiting medical practitioners at the Wesley, as well as all other clinical governance responsibilities there. Lewis is also the Chief Medical Officer for Uniting Care Health. He is a Fellow of the Royal Australian College of General Practitioners, the Australian College of Health Service Management, and the Royal Australasian College of Medical Administrators. He's also a fellow with the Australasian Association for Quality in Healthcare and holds a graduate diploma in sports medicine. Lewis continues to work actively as a general practitioner around his duties as Director of Medical Services. Welcome, Lewis. Our next panellist is Reverend Helen Dick, who's the Director of Mission for Uniting Care Health. Helen's master's research into the effects of patient deaths on aged care staff has been published internationally, and she's presented at palliative care conferences in Canada, New Zealand and Australia. Helen is currently a research PhD candidate at the University of Queensland for the topic of exploring the spiritual and religious beliefs of aged care nurses and nurse aides in the face of death, dying and suffering in the workplace. Welcome, Helen. Our next panellist, Associate Professor Greg Scalia, is a cardiologist with a special interest in clinical cardiology, valvular heart disease and echocardiographer. Associate Professor Scalia has been practising at the Wesley Hospital since 1999. Associate Professor Scalia was the first dedicated echocardiologist to join Heartcare Partners. He's a member of the Royal Australian College of Physicians, the American College of Cardiology, the American Society of Echocardiography and the Cardiac Society of Australia and New Zealand. Welcome, Greg. Terence Seymour is the Chief Strategy Officer for Uniting Care Health, and he focuses on the provision of first-class patient services and the creation of value. He has extensive experience in both the public and private sectors and has developed considerable expertise in the areas of patient care, operational efficiency and business development. His employment history includes periods as an executive and business leader with international settings, and his interests lie in improving the patient's experience of the healthcare system. Terence has previously worked as the General Manager of the Sunshine Coast Private Hospital, been the Director of Human Resources at Uniting Care Health, been an Assistant Commissioner for the Australian Tax Office, Director of Tri-Delta Consulting.
Didn't know that about you. I didn't know that about you.
Yeah, I didn't know that about you either, Terence.
Need to check that CV next time.
That might be quite helpful in the years ahead. General Manager of EMD Workforce Development, Director and Area Lead for Ernst & Young Consulting, and has also been Director and Area Lead for Capgemini Ernst & Young. So if we could welcome Terence Seymour. Associate Professor Deborah Parker is the Director of the University of Queensland's Blue Care Research and Practice Development Centre and Director of the Australian Centre for Evidence-Based Community Care, which is a Joanna Briggs Institute centre. Deborah is a registered nurse who has specialised in palliative care and aged care. She is currently a consortium member of the Specialist Palliative Care and Advanced Care Planning Advisory Project to support palliative care and aged care in Australia. Her role on this project is to lead the evaluation of the national program. So if we could welcome her as well. Dr. Ralph McConaughey has a Master of Primary Healthcare majoring in Palliative Medicine and has also received a Master of Management of Pain from the University of Sydney. In 2007, Dr. McConaughey was appointed Director of the Wesley Palliative Care Service. It is his desire, wherever possible, to reduce the burden of disease and its treatment, provide practical assistance and support with the full involvement of patients and families, allowing an increase in their choice and control. Dr. McConaughey is also a Fellow of the Australasian Chapter of Palliative Medicine. If we can welcome Ralph. Dr. Richard Kidd has been a general practitioner for 27 years and a practice principal in Brisbane's northern suburbs for 21 years after volunteer experience in Papua New Guinea and Queensland. He's had significant rural work also in Queensland and used to work in Serena. Dr. Kidd has special interests in men's health, palliative care, geriatrics and mental health counselling. He's also a former President of AMA Queensland. Welcome, Richard. Dr. David Schleck is a radiation oncologist with clinical interest in the management of stereotactic radiosurgery. Dr. Schleck qualified in medicine from the University of Queensland in 1979 and completed his residency training at the Royal Brisbane and Women's Hospital. He then went to St Vincent's Hospital in Sydney to train as a radiation oncologist. After attaining his qualification as a radiation oncologist, he returned to Queensland in 1990 and commenced employment at the Wesley Cancer Care Centre, now known as Premium. Dr. Schleck is a Fellow of the Royal Australian New Zealand College of Radiologists and a Senior Lecturer at the University of Queensland. Welcome, David.
Thank you.
Now, ladies and gentlemen, as you know, we're very fortunate to have Tony Jones return this evening. And before I welcome Tony to the podium here, I'll outline some of his achievements. Tony Jones is one of the ABC's most respected journalists with more than 20 years experience in radio and television news and current affairs. He anchors Lateline on Wednesday and Thursday nights. Tony began hosting the award-winning news and current affairs program Lateline in 1999. In 2004, he received a Walkley for Best Broadcast Interviewing for a series of Lateline interviews. Tony joined the ABC as a radio current affairs cadet working on AM, PM and The World Today. In 1985, he was seconded to Four Corners as a reporter, and 1986 joined the Dateline program on SBS. Tony returned a year later to the ABC reporting for Four Corners, where in the next 3 years he won a number of awards for his current affairs coverage, including a Walkley Award, a Penguin Award and a gold medal in the New York Film and Television Festival for a story on the exploitation of Antarctica. In 1990, he went to London as a TV current affairs correspondent, covering such stories as the collapse of communism in Eastern Europe, the reunification of Germany, the Gulf War, the war in the former Yugoslavia, the fall of Kabul in Afghanistan to the Mujahideen, and the collapse of apartheid in South Africa. Tony won a Walkley Award with Kerry O'Brien and Dugald Maudsley for Late Line's coverage of the end of Gorbachev's Soviet Union. Tony returned to Sydney in 1993 as executive producer of Foreign Correspondent, and then from 1994 to 1996 was the ABC Washington's correspondent. He returned to Foreign Correspondent in 1997 as a reporter and covered the war crimes in Bosnia, which won him a silver medal for best foreign coverage in the New York Film and Television Festival. In mid-1998, Tony returned to Four Corners. Please welcome to the stage the Master of Q&A, Mr. Tony Jones.
Thanks very much, man. That is the most complete bio of me I've ever heard. I think I could probably just publish that as a memoir. Except you did leave out my brief stint as a tax commissioner. Oh, that's a surprise to everybody, isn't it? Terence and I used to sit next to each other. Welcome to tonight's Q&A. Can I start by suggesting that if you do have a banner to unfurl in protest against the budget cuts, or if you want to do any chanting, you want to throw a shoe even, get it over with now, all right? This is the time to do that. And I'm glad I got a few chuckles there, because I thought we ought to start tonight with a bit of a laugh, because we probably won't have many more. At least that's what I thought until I met our panellists, because my assumption is that tonight's topic is one where jokes or any form of humour might be out of place. Palliative care. The end-of-life decisions and the ethical dilemmas that arise as people approach death with terminal illness. These are not laughing matters. But having spoken to a few of these panellists, I'm not so sure there isn't a bit of humour in it. To start with, I remembered a phone conversation I had nearly 25 years ago with a cousin called Chris, who was dying of a brain cancer. I was in London at the time working as a foreign correspondent, and he was back home in the final stages of this rather nasty cancer. And all he wanted to tell me about on the telephone was the Fawlty Towers episodes. He was watching one after the other after the other. He wasn't a particularly religious guy, and he was facing death, but all he wanted, actually, apart from pain relief, was a bit of a laugh. He wanted to remember how to connect back to life. I think that's the best way to put it. He wanted to remember a little bit about the life that he was about to relinquish and what was good about it. It made him feel more human to have a laugh. And I remembered my friend too, the writer, journalist and contrarian Christopher Hitchens, after he'd been diagnosed with stage 4 cancer of the esophagus, a particularly nasty cancer, as you would all know. He described that moment of revelation when he found that he had this cancer as like being taken as a reluctant deportee across an invisible border from the land of wellness to the land of the sick, to the realm of the ill. Christopher dwelled in that realm for a year or two, actually, before the cancer finally killed him. But he remained a kind of rebel in that realm, a sort of dissident, as he always was in the world, an unwilling citizen of the land of illness, right up to the day of his death, writing, reviewing books, castigating the Tea Party for its flawed thinking, conducting numerous interviews, and radio, television interviews with me even in Washington. And in those last days, and his friends and his family remember this, the very last days of his life, he was joking with his friends and family and scribbling down both profound and humorous observations on scraps of paper. They've now been published, of course, because most of them were little flashes of brilliance from a dying man. These memories of Chris and Christopher are what came to my mind, and they made me think of the idea of a good death. What could a good death be? And when researching this area of palliative care and speaking ahead of this Q&A to some of the practitioners of palliative care, I realised there do exist in the world a group of passionate and highly qualified people devoted to the idea that a good death should not only be possible, but it should be considered the right of every person. And this led me, of course, to a very obvious thought. Everyone is born and everyone dies, so why doesn't society provide the same level of resources and care and attention at each end of that equation? We know, of course, when you're born, you get tremendous care, you get tremendous number of resources, and that's logical and as it should be, but at the other end, does it still happen? Or does it happen? And should it happen more? In fact, I learnt only a few minutes ago that palliative care, the very notion of it, is only about 14 years old. The word, the phrase, is only 14 years old. I didn't realise that until we were having dinner just a short time ago. Anyway, I imagine that all of these things are things that we don't like talking about. Here we are gathered here, all of us today, and we're going to do it. And do you know what? The more I spoke to these people on the panel, the ones that I had a chance to speak to in advance, and the more I thought about it, and the more I read the studies about it, the more I realised what a mistake it is to sweep this kind of discussion under the carpet. When I thought about it, my own biggest fear of terminal illness, and I dare say pretty much everybody's, apart from the obvious personal consequences of premature death, was that I might die in pain, in some permanent twisting agony that would have me crying out for a quick death. And I know that is a universal fear. The studies show that the fear of pain, existential fears and psychological issues are at the very top of the list of concerns for both patients and families. So we're about to talk about what modern pain management can actually achieve. How much of that fear can be taken away if people know there really are ways to relieve their pain and many of their symptoms. And how much does that actually change the debate around euthanasia? We've seen those two doctors down in Victoria. We might talk a little bit about that as well, both of whom have said they killed patients quite deliberately as an act of compassion. Anyway, how much can a caring, thoughtful, multi-discipline crew of palliative experts relieve the physical and spiritual pain of dying? And how do you best engage their families in this process? Is it best to have a go-to family member, a kind of surrogate who does the decision-making, or is it best for families to behave in a kind of consensus way in how they deal with their dying family member? How and when do you get someone with terminal illness to put it in writing in an advanced care plan, what they want to happen to them? How and when they should be resuscitated? When should they undertake final surgery, radiotherapy in the final stages of life? And how does any of this complex stuff happen out in communities where many people actually do want to die in their homes? What's the role in all of this of the modern GP? So many questions. And how much more important is that when you live in remote or regional Australia? And what do large numbers of people who die in nursing homes, what about them? Many of whom, perhaps a large majority, are suffering from dementia. So there's a lot to talk about. And I'm sure that you as an expert audience will have questions. I know that a few of you have sent questions to us. They can be as technical as you like because we've got the panel that can answer those questions. They can be as philosophical as you like because we can do that too. As I said, we've got a few questions sent to us and we will go to those, as many of them as we can anyway. But I'm hoping, in fact, that listening to the conversation, you'll get on your hind legs. There are a couple of microphones circulating. And we'll do it that way, because that's how Q&As work best. I'm going to go join the panel now, and we'll start the process. Thank you very much. And our first question, we'll go straight to the audience, is from Dr. Margaret Cotter. Where is Margaret? There we go. We'll give you a microphone, Margaret.
Is providing palliative care a human right?
A human right. Ralph. Well, there's a few people putting their hands up. We've got some great panellists here who just want to get into this. I'll start with Ralph and then we'll go down the panel.
Short answer would be yes. I think we'd all probably agree the right to a death that's dignified and comfortable ought to be universally available. Of course it isn't. And even in a modern first world country like Australia, there's a large percentage of the population who doesn't get the level of care and support they probably need. If you go to third world, you go to Eastern Europe, it's very hard. And particularly Eastern European countries where there's a sort of opioid phobia, it's very hard to even provide adequate analgesia for anyone. And the regulations to get the drugs, you finally get approval, you go to the pharmacy doesn't carry the drug. So there's a lot of inequity and a great deal of suffering associated with that.
Is there inequity here as well? I mean, you're in a private hospital, obviously people get the best care in private hospitals. What about beyond that?
I think there probably is, yes. Yeah, I do. And part of that is the will and the desire of medical and nursing practitioners to assist the patient in finding what they need to be comfortable. Some of it is rural isolation, some of it can be financial. So yeah, I do. I think there's significant inequality, and particularly if you go to Indigenous populations, it's worse still.
We'll have more about that later. Richard, your thoughts. Is it a human right, palliative care?
Absolutely, and it's recognised within the international human rights law, and the United Nations Article 12, which is the International Covenant of Economic, Social and Cultural Rights, and Article 7, which is the International Covenant of Civil and Political Rights, absolutely states that countries are obliged to take steps to ensure that patients have access to palliative care and pain treatment. And the United Nations Special Rapporteurs on Health and Torture very much have made the point that where people are denied access to palliative care, it really is tantamount to degrading treatment and is cruel and inhuman. So absolutely it's right. But as Ralph said, there is this terrible iniquity in the world. 58 million people die each year, and WHO says 60% would benefit from palliative care, and at least 80% of those people don't get any kind of palliative care. And oral morphine only costs about 1 cent per milligram. It's incredibly cheap. It should be available everywhere. And here in Australia, to follow up, 147,000 people died in 2011, and Palliative Care Australia, in its submission to the National Commission of Audit in January 2014, claimed that 107,000 of them would have benefited from access to palliative care services, but only about a half of them actually got access.
Deborah, what do you think?
Yeah, look, I think obviously most of my work I do in aged care. So I think when you talk about is there inequities, absolutely the inequity of can you get a specialist palliative care service to come to your aged care facility? It's a postcode lottery. Do you need a specialist team for everybody that's dying in an aged care facility? No, but you do need staff to have training. But the government, the federal government, doesn't provide a lot of money for that extra care that's required when people are dying in aged care facilities. So it is a human right. I think there is massive inequities, though, that happen in aged care.
David, what do you think? You're an oncologist. I'm interested in your perspective on this. I mean, you obviously work very closely with the unit at Wesley.
Well, I think you've touched on a couple of the points. One is it's important to state these sort of things in charters, and I think for a first world country that's important. And yet people die in Turkish coal mines and Nigerian bomb attacks and so on. So most people don't have access to any of this. And a lot of it is the purview of a very privileged group who attend the Wesley Hospital. We've got first-class services and facilities, and extending out from there is part of our charter. I think we've got to take some of this argument forward. It falls to us to do so.
Lewis, can you do that?
Well, just to answer that first question about whether it's right, it's very easy to say, right, I'd like to send Richard's link to a number of people, and starting with all the health funds that I have to negotiate with, and say, did you know that was actually a right to have palliative care, so you might fund it for once in a while?
Richard's a brilliant conch, isn't he? I mean, I knew that if someone had that information, he would.
Yes. But the real challenge is that palliative care extends beyond the Wesley's hospital's borders, as Deborah said. A lot of palliative care, in fact, fundamental palliative care is provided in the community by general practitioners and community nursing services, particularly together. But the coordination between hospitals such as the Wesley, public hospitals, the community can be complex. That journey for patients and their family can be hard to negotiate, and you're in such a vulnerable space in your life that you need others to help you with this. And very well-meaning, dedicated people in different pockets of the community and the hospitals are focusing on that. But the lack of coordination often is a difficulty for patients and their families. And then fundamentally, if it's a human right, and particularly community-based care, which often requires GPs, which there are people in the audience here who would need to go to homes to do that. I'm just trying to work out exactly then how they get that $7 extra that they're going to be getting from shortly to actually, I'm not sure if the patient has to pay for that actually.
They only get $2 of that. You've
I'm not
forgotten
sure
how
you're
that
going to get that
actually
money.
works.
But that to me is just a fundamental part, understanding that palliative care, if it's going to be in the home, it's going to be done by community-based services. It's pretty hard to fund that under the current circumstances.
How do you fund it at Wesley, by the way? I mean, does it run at a profit, at a loss? How does it work?
Well, essentially, we just strap Ralph to the front of the hospital and we just keep bashing him around until he sees everybody, and then we send him home at 10 o'clock at night, really. And we pay him a pittance, and we get a pittance for it as well. But in fact, as I say to patients, their families, the health funds, we're all insured. Most people here probably pay health insurance, and you don't know that your insurance, just like car insurance, really only pays for what they want to pay at the end of the day when a claim is made. And if you make a claim for palliative care, they go, well, that's worth this amount of money.
Not very much in most
about
cases.
$500 a day, and it costs Wesley just to open its door about $700 a day per patient. So we run at a significant loss per patient per day. But we also have a medical model which involves having specialists like Ralph and his team. And they're not funded either by health funds or Medicare, so unless it's 5-minute medicine, and Ralph doesn't practice 5-minute medicine. So we get a double whammy because we have the hospital's funds, we pay Ralph as an employee. So overall, we're pretty much screwed. So,
well, I mean, I took you down this path actually because there is a serious point to be made, and that is you can't have a human right to have a particular form of care unless you've got the money, the public money usually, to fund it in the community.
Well, I've been at Wesley 10 years, and I was reflecting that probably every week for at least 3 to 4 years, I've been in a meeting or in a discussion or had a question asked to me of why we do palliative care, how can we keep funding palliative care, how do we fundraise, how many more biscuit tins do we have to sell to fund palliative care, why we're in palliative care, and isn't it great that we're in palliative care? And we just had a fundraising event this week for it. And for something that's meant to be a fundamental right, and for something that is, clinically pretty easy to understand and explain from the point of view of the benefit to the patient and their families, to struggle week on week to actually look at just the straight out money for paying it, it's almost ridiculous. I don't have that discussion, by the way, with other care, which is funded pretty well. Now, Wesley looks at it that, well, we're in the business of cancer care. We do a lot of surgery, we do a lot of patients. In fact, we have the largest cancer care campus in Queensland, public or private. And so morally, if you're at one end of that clinical spectrum, you should be providing all the care. But, and that's, I think a good position to be in philosophically. But there's a lot of places out there that pick and choose what part of cancer care they're going to treat and be involved in. They essentially take the parts which are very profitable, good turnover, low risk, and then when it's time for someone to look after them, to the community, to a public palliative care, to the Wesley. Yeah. And I think that's actually where the inequity is too.
Let me, well, I want to hear from the other panellists in the middle, but because we've raised this issue of how you pay for it, etc., I'm going to go straight to former tax commissioner or whatever, Terrence, who's in management. And look, I mean, well, tax commissioners and tax people, they're bean counters, aren't they? That is the essence. And in management, you must take some of those skills in. I wonder, do you see it as a human right that you keep basically funding the gap in what's here, because I think we're hearing $500 you get back, and there's another $400 or whatever that needs to be made up internally by the hospital. Is that something management will keep doing forever?
For Uniting Care Health, for the foreseeable future, the answer is yes. So for Uniting Care Health, this is part of. This is who we are. It's the services we provide. Lewis said we provide an enormous number of oncology services, and this is part of that. But remember, palliative care is not just about cancer. Palliative care is associated with coronary disease, it's associated with motor neurone disease, it's associated with, and the list goes on. So it is not just a cancer-related treatment. And for us, it is about the essence of what Uniting Care stands for. And it is about an obligation to the community. So we do cross-subsidise between our services, but that becomes a significantly more difficult juggle as you look at the whole of the services, clinical services that you provide at a hospital. For example, the Wesley has 14 licensed palliative care beds, and as having licensed beds, you can charge somewhat or get some funding from the insurance companies, from the health insurance companies. If you look at our other hospitals and the bulk of private hospitals across Queensland, they do not have licensed beds. They do have palliative care patients, many of them. So many patients come in, but you can't bill for them. So the actual loss that you're making is significantly higher than what Lewis was explaining.
Okay, I want to hear from our last two panellists on whether the basic question, human right to have palliative care?
I think human right is a wonderful term, but I think we have to be careful that we don't just mean a human right for middle-class Australians, that if we're going to call something a human right, then it applies to our neighbours and people in rural and regional remote communities in Australia as well. Having worked in the Solomons for a little while last year and seen that healthcare in those settings, even to have constant running water, clean water, and to have constant electricity supply is a luxury, then I think if we're going to say this is a human right, we have to think about what's our responsibility to our neighbours as well as to ourselves. I'd also like to back up what Deb was saying about the inequities in aged care. That was my background before I came to Uniting Care Health. And I've seen nurse aides with much less training than Ralph's team have running around looking for mouth swabs because there just aren't enough, because the funding's not there. The funding at the moment is to keep people in the community. And so it has to be a human right across the board, not just for middle-class Australians.
Okay, and finally, Greg, what do you think as a cardiologist?
I think that universal care is in fact a human right, and to artificially pull palliative care out as a sub-fraction and say this is a human right, and that's the way the question was coaxed, but I mean universal care is a right. And I think what's gone wrong for palliative care, if I might, is that it's the line between full throttle active treatment, palliative but not end-of-life treatment, and then those few days of end-of-life, which when we all trained is the only thing that we recognised as palliative care, those days with the Grasby pump and the morphine and the cushions around the bed and so on, and the family and there's candles and so on, which is what we all learned. That middle bit from full throttle active to end-of-life has been lost. And where do you start calling something palliative care and stop funding it, for example? Many of the things that we do are palliative, but they're fully funded because it's a sort of a version of an active intervention. And I think one of the things that's gone wrong with the politics of palliative care is with the blurry line through that pathway and where the funding stops.
Okay, very good point. Now, I'm going to throw that straight back to Ralph for an answer, because it really does beg the question as to what palliative care is, who is it for in the modern world, and certainly in your context, because it isn't just for literally end-of-life events, is it? No.
Well, I guess, broadly speaking, it's for anyone with a life-limiting illness, and that's cardiac failure, it's cancer, it's dementia, it's any of those. And I guess the goal of palliative care is to provide better quality of living as opposed to helping people die. So what we're really interested in is furnishing a life that is actually worth being here for. So a lot of the role, when I started, it was drop your patient off at the door. If they've got less than 2 weeks to live, if they haven't, you keep looking after them until that's the case. And I guess that's changed a lot, because what's been realised is that we can value add to people and their experience through their treatment if we're involved much earlier in the piece. So sometimes...
How much earlier? When effectively should palliative care start? What's the starting point?
Sometimes it starts at diagnosis, I think, and sometimes that's because they've got like Christopher Hitchens, who's got an advanced disease, but sometimes people present with frightful pain, and it may be a cancer that can be cured, but you may be involved because you can relieve their suffering while that treatment process takes on. Certainly, from a technical viewpoint, a bit of a line's been drawn that at the time people experienced the first development of metastatic disease, then awareness should come up that maybe this is the time to invite palliative care to be involved. The problem is what people then interpret as palliative care, because the general community thinks, oh no, 2 weeks to go, the guy's coming in with the horns and the tail and he's going to tell me a bad story. And, you know, if I don't make someone cry every day, I feel like I'm not doing my job properly. And often that's the case. If people
so
realise...
do you need to, if someone comes to you
Yep.
and been referred because they've got the first stage of a metastasising cancer, you would say to them, look, you could be with us for many years, would you? Is that how it works?
Well, and the emphasis is on control of symptoms and support of that person as an individual, holistically. So we want to be interested in their psycho-spiritual existence, their family existence, as well as their medical experience. And really, we're not there as a harbinger of doom that says, righto, mate, you've had it, I've got you, and we're going to tuck you in. It's really about what do you want from this journey and how can we make it work for you in a better way than it might otherwise. So 70% of our job is in that area, in the away from the end of life, and 30% is that last few days. But 70% of our patients in the ward would go home.
Let me go back. I'll come to you, Richard, in a second. I wanted to hear from the oncology specialist, because I know in the United States, the Society of Oncology has actually made a recommendation, a formal recommendation, that on the diagnosis of a metastasising cancer, you should not only be in the care of oncologists, but of palliative care specialists.
That's right. They have made that pronouncement, and that is quite a nice idea, but in the setting of scarcity of resource, very difficult. And in addition, it's not always such a comfortable thing for the patient. You've developed metastasis today. You need to meet the palliative care people is not necessarily a comfortable thing. In addition,
psychologically, you mean?
Psychologically, and in addition to that, cancer has become a chronic disease rather than an acute and terminal thing necessarily. So people can have a chronic illness like cancer for donkey's years, and so you may not require a palliative care person at the development of the first metastasis, depending on the setting, the cancer, and the treatments available. So that idea of first metastasis, meet a palliative care doctor, is the bar that's been set. But it's not going to land in Australia anytime soon.
Richard?
Going to your question, I'd suggest that when do you start palliative care might be when do you start the discussion of palliative care. And Palliative Care Australia did a lot of work a few years ago. I was involved in the national task forces around developing the palliative care approach to residential aged care. And the idea of that is that as people are admitted to aged care facilities, the palliative care approach begins. And so basically you're preparing people for, and their families, when it's very often the families with older people that you actually really need to do the work with, that as this person is going through successive losses in their health and their social life and their whole personhood, it becomes more and more relevant to be talking about palliation. But in actual fact, in terms of when do you start, I'd say you should start the discussion with people who are 30 or 40 or 50 years of age. And GPs do this comprehensive health assessment on people at the ages of 45 to 49. And I think that's a very good time to have the discussion and get advanced health directives done, to be talking about advanced care planning, because for any of us, we could have some event that might actually take away our ability to dictate for ourselves how we want to be managed in the months or days that we have. If we have a stroke or a severe heart attack and end up being severely hypoxic, or a head injury from a car accident or a football field injury, we should all actually be thinking about how do we want to be looked after in what might be our last days or months.
All right, I want to go back out to the audience. We've got, as I said, I haven't seen too many people with their hands up yet, so start doing that, guys. We've got a question, however, from Michael Gilman, Dr. Michael Gilman. Where's Michael? Down here. Michael, we'll get a microphone to you. Yes, it's coming. It's on its way. It's there.
Thanks very much. Ralph said that the aim of palliative care would be to help people keep living. However, there are some terminally ill patients who do wish to end their life. And whilst we know euthanasia is illegal, is there any role where patients can have some control or involvement in ways to hasten their death and have the involvement in that?
A big question, Ralph. I mean, how do you respond to that? I mean, I'm sure, and perhaps you could tell us, that patients must ask you to hasten their death.
thanks for raising that, Michael. It's so straightforward. I guess it's very difficult. It's not infrequent that people will say, in all different ways, can you do the right thing, Doc, for me? Or when the time comes, you'll look after me, won't you? And various other euphemisms. And sometimes I say, have you got a pill and can you give it to me now? Because I don't want to go on. And I guess my response, and most people who work in this area, would be to ask, why are you asking? What's behind your request? And I think there's if I can use the word hardcore, it might be the way to describe it, a small number of people who have perhaps all their life subscribed to the thought that they should control the time of their death, and that no matter what their experience at the end of life is, they want the right to choose the moment it should end. And I think the number of people who hold that belief is not huge. It's certainly there.
Should it be a right for them? We're talking about the right to care. Should you have the right to die as well, if you wish?
I think that's probably becoming something as a society. Perhaps a general community might accept is more a right that perhaps 20 years ago we would have said not, that the want to take your life is an illness rather than a simple decision. I suppose I still belong a bit in the illness department rather than this being a clear and rational choice. My response, I suppose, to people is, in general, what I want to do is let people have control over the course of their disease process and over the choices that are made in terms of how they're cared for. So in that discussion, some of it is understanding why they ask, and sometimes because they don't feel valued. And the question they ask you is, the subtext is, will you confirm I'm worth looking after, rather than will you kill me? And for others, it's because they feel there's a family pressure and they're in the way, and ending life quickly would save people a lot of trouble. A lot of mothers think that, they don't want their kids fussing about them. So there are a variety of causes, and some people are frankly depressed, and really you need to treat their depression. The desire to end their life disappears. Others are afraid, as Tony said, of suffering and pain and loss of dignity and incontinence and being dependent on other people to care for them. And a lot of those people, when they come to see what that process involves and the way they're cared for, again, the request for life to end disappears. But there remains a percentage of people who is their desire. Technically, we can't, in terms of hooking them up to some machine or giving them a syringe of medication and killing them. I will frankly talk to people that they've got choices.
Are there I know, because I had a conversation with you earlier, so I know that there are even people in your own hospital who think you're the euthanasia guys.
They do.
Give the sick patient who wants to die to them, because that's where it'll happen.
Yeah, that's certainly been said as bluntly as that, and other times a bit more subtly. But certainly there's a perception that's what we do. We, get people dead. So we let people know there are ways to let life end. They don't have to have their pneumonia treated. They don't have to have their high calcium returned to normal. They don't have to have a flu vaccine if they're in a nursing home. There are a number of choices people can make that allows life to draw to a close. Apart from all that, there's still a group of people who want you to kill them. And I guess that's the group in the end that we can't assist. But we would spend a great deal of time trying to understand why that request is there.
What happens with that core group, those people who've made that judgment? Have you had a situation where they've gone home and taken their medications with them, just taken everything?
Yes, yeah, certainly. Sometimes it's been surprising people who've never raised that conversation at all, go home with a month's supply of analgesia and take it the very next day and die. And that's often quite shocking for us because they're people we haven't anticipated. And mind you, trying to put yourself in their shoes, I can understand why they do it. And I've often wondered if I got my favourite disease, which is motor neurone disease. It's not my favourite. Whether I'd be one of those people. Would I, in fact, end my life prematurely because I don't want to go down that pathway? So I've got a lot of empathy and sympathy for people who feel they don't want to have that experience. So we do our best for the bulk, and for a small number, we can't assist them in that way.
How would you feel? I'll come to the rest of the panel in a minute, but it's such a fascinating opportunity to actually hear what you really think about this. So how would you feel if you did have the legal right to do it. As a doctor, would you feel that would somehow change the whole kind of basis, the interaction between a doctor and a patient?
I think it would. And for me, I probably still wouldn't euthanize anyone. I think it's fundamentally not why I have this job. And if it's legislated, I'd like lawyers to do the killing rather than doctors. You know, we could have lawyer death squads who'd come and do it. I think that'd work a lot better.
Martin Amos, the writer, who's actually...
Thank you.
That's an applause for the lawyer death squad, not for Martin Amos yet. Okay, there are not many lawyers in the room, obviously, and I'd have to agree with you. Give them the opportunity, see if they'll still do it. Anyway, very few lawyers have blood on their sleeves, it has to be said. Martin Amos, the writer, who's actually predicting, slightly satirically, a war between the old and the young over resources, with the ageing population who've got everything, the rich houses, the cars, the good superannuation package, all the rest of it, and the young who end up flipping burgers for them are going to feel pretty anxious about this. And he actually had a suggestion that they should build euthanasia bars on street corners where those brave enough to do it should go in and have a martini and get a medal.
Yep. And there'd be a lot of pressure to do it. I think, that's... But
is that what's happened in Holland, in places where they do have the opportunity?
Not quite euthanasia bars, but I mean...
No, that was the satirical side of the equation.
But there's
the
about...
pressure, I meant.
Yeah, I think there is. There's about 2.5% of the people who die in Holland die by euthanasia. And of that 2.5%, there's a smaller percentage. I can't give you the figure exactly, but it's not inconsequential, probably in the order of 600 or 700 people who have euthanasia without their consent. And the interesting thing is that's actually reported, so it's an open figure. So there's meant to be a number of safeguards and checks that before you're actually euthanized. I think the interesting thing, if I don't blather on too long...
Well, I am going to cut you off in a moment, but just finish your sentence.
It was looking at the Northern Territory experience in the year or so when the palliative care wasn't established and euthanasia was available. The safeguards put in place by the legislation were flaunted and got around on almost all of those deaths. The criteria that were set were dodged or not fulfilled, so those people could be euthanized. So that very setup actually allowed it to be fraudulently applied. So I don't have a lot of confidence that we're going to protect people.
Let's hear from Richard. And we know that two doctors in Victoria I just mentioned have both admitted and so basically challenged the law to come out and prosecute them because they say there ought to be a big debate about this, and what they did was the last compassionate act you could do for somebody. What do you think?
It's a huge question with so many different facets to it. To go back to part of the earlier question, and Ralph actually touched on it, and that is that I think a very significant number of people who want to meet death on their own terms do so without discussing it with us. And I'm mindful of a colleague who had a 93-year-old patient who had been extremely fit, extremely well, was still driving her car, and she took an overdose of sleeping tablets and had left a note to the effect to her family, "I've had a great run. I feel that if I have another day, it'll probably be a day where I'll have a stroke or something dreadful, and I want to go now." And she did. And 6 months later, her best friend, who was 94, did exactly the same thing and wrote much the same sort of letter. And I don't know about the first one, but the second one, the 94-year-old had basically gone to her GP and got one bottle of sleeping tablets every 6 months or a year, and she had been storing them up for about 5 years. And she had clearly had this plan for at least 5 years, that when she felt the time was right, this is what she would do. And she did it. And the GP, on reflection, is quite certain that person, she missed her friend, but she wasn't clinically depressed. But it does touch on suicide, and that suicide is a huge thing. At least twice as many people die through suicide as are killed on the roads. And some of those suicides we can see are depression, but sometimes it would appear that it's people who may well not be depressed, but decide that they're going to meet death on their own terms when they've had a good life and maybe they've had some bad news. And it touches on a whole other area around electronic health and the personal controlled electronic health record and how people access their results. Because if someone gets the news that they've got, for example, Dr. Yaxley can relate to this, a high PSA, and they think, oh my God, I've got cancer of the prostate, and they go and kill themselves before they go and talk to their GP or the urologist, it may well not have been cancer. But so there's a whole lot of layers around this and how our patients who have become so much more sophisticated can handle information that we give them.
Okay, let's go back to what the questioner was asking specifically though. This is people who are in pain, presumably people with very difficult conditions, maybe approaching the end of their life and saying, help me out of this now. We hear that's actually happening. What do you think about that?
Well, the exciting thing in the last 5 or 10 years is that we have got so many better ways to be able to help people with all sorts of pain that in the past we may not have been able to. 10, 15 years ago, maybe we really just had narcotics and a few other things to help us. But today, for example, we've heard how someone who has got a blocked artery in the leg that's causing incredible pain can get basically a palliative intervention to get a stent put in and get the blood supply back into the leg. It's not going to increase their longevity, but it's going to make a huge difference to their pain. And someone getting radiation treatment to debulk a tumour that's causing terrible bone pain may not change their longevity at all, but it's going to make a huge difference to their pain or their suffering. So there's an awful lot more we can do now to maintain people's dignity and help them towards a good death on their own terms, which doesn't necessarily mean euthanasia.
I'll just bring in David there since you mentioned that. Yeah, I mean, do you find that you're now doing very targeted interventions for people just to relieve their pain?
Very much so, and often in the very last moments of life too. It's surprising, we think of radiotherapy as being such a big undertaking and perhaps an expensive undertaking. It's usually at the start of one's cancer illness, but it's actually still useful right up until the last day often. So we have a very close relationship with palliative care facilities and use it at that point. I too fall into the camp of the other doctors here where I don't feel at all comfortable with euthanasing, and we don't do that, and that's not for me. I think it's so hard to keep people alive on the one hand that would be of no interest to me to be engaged in that sort of activity.
It's quite hard to kill them too.
I think the other thing I'd say is that we've looked at this in our centre, and to tease out amongst the people who say that, and they often say it surprisingly early, as was mentioned, that would you mind killing me, by the way? There are a couple of things to tease out. One is the depression that can be treated. There's another issue that we've looked at, and it's not widely appreciated, I think, and that's hope. Hopelessness is the despair that says, look, I wouldn't mind going today if you don't mind. But hope actually can be fostered by various cognitive processes. So it's an emotion, but it can be improved. And hope for someone in the very last week of life can be something small, like I'd hope I get a cup of tea with my family. And it's very different for someone who's fully mobile at the start of, say, a prostate cancer treatment. But the idea of fostering hope is something that we really haven't come to full grips with, and we don't have good strategies for yet.
I'm actually going to go to Helen because you've raised that, because I'm wondering whether there is a spiritual side to fostering hope, and is that part of your job? And is that part of the job of chaplains and others within palliative care units?
I think it certainly is. I think that one of the spiritual issues that confront people with an end-of-life diagnosis or a terminal diagnosis is, well, is this it? And certainly the fear of pain and abandonment and loneliness are big factors in how people confront those issues. And the people who've spoken to me and said, I don't know why God doesn't take me, I'm ready to go, it's always been around those things, all the things that you were talking about, Ralph, are family pressures. Families literally putting pressure on to say, we will be better off when you go because we've got all these debts that need to be paid and we can't manage to come in and see you, it's just too hard for us.
Isn't there a special hell for people like
I
that?
hope so, to be honest. And so if people can be given hope that there won't be as much pain as they anticipate, that there will be people around who love them and care for them, and that the things that are very special to them in their lives that give their life meaning can be made to happen, whether it's the cup of tea with a family. One patient that I remember his most special thing, the most sacred thing to him was the hawthorn. So to be able to watch them win a match was what was keeping him alive.
Yeah,
so,
no, I would have thought, winning the Ashes back or something like that.
So for each person, it will be different, and certainly part of the task of chaplains is to find out what it is that gives people's lives meaning, and what are the things that they hope for, and as Ralph said, finding out how that can happen, how we can
You're
make
right.
that
I
happen.
made that point in an informed way because my father, who actually thought he had a terminal illness, but it turns out he's got a few years left yet, desperately wanted to see us win the Ashes back. Some things like that. But have you actually had to confront the notion, or the individual who says, I'm in such terrible pain, I just want out of this now? That's the sort of extreme case that I would imagine that would be hard to argue against.
It is, but my experience has been that pain can nearly always be treated. And it's really a case, particularly in aged care, of clinicians taking seriously the person's complaint of pain and looking at what can be offered to alleviate that, to palliate that pain. And I've seen people who are desperate. I'm in such pain, I just want to go, I don't know why I'm here. And then when that pain is alleviated, I can remember one lady who was out playing bowls 6 months later because her symptoms had been palliated, alleviated to that extent. So pain and fear of pain is a huge issue, and if people can have hope that can be relieved, then it makes a big difference.
Lewis?
You can put a billboard up that says, if you have chest pain, come here. And people in Brisbane know what to do. But if you put a billboard, if you need palliative care, come here, is not a topic that people can really want to relate to or even confront. And the problem I see in my role is that it's not, the term ignorance sounds terrible, but it's a lack of understanding, not just in the community, but in healthcare, by healthcare professionals. Unfortunately, at Wesley, we have a reasonably good culture of understanding the role of palliative medicine, but even at the Wesley, we have people who have difficulty understanding that it's time to involve the palliative care team, to look after the spiritual side, to look after the clinical side, medical and nursing, to look and see whether there might be some palliative treatment they can have. Some of our doctors and nurses feel it's a failure, that when it's time for palliative medicine, I have failed my patient. They find it difficult to continue to be engaged. They, in fact, feel it's time that they're handing over something where they may have battled with that patient for quite a long time for a treatment or treatment options. And that can be difficult because with the patient needs to, if they get a sense of that, that can be quite disturbing for them. If it seems that they're losing out, that the doctor they're being with or the team they're being with no longer have anything to offer themselves, which is why involving palliative care team earlier is better, because when you do that end of stage type of transfer, it is more obvious that you're giving up hope, or you're potentially giving up hope. We actually count at the Wesley as a KPI patients who die in the palliative care unit within 24 hours of referral. The reason we do is to target clinicians to be able to make sure they understand that a late referral doesn't help anyone. It doesn't help the palliative care team, and in my goodness, it doesn't help the patient and their families. We look at people who arrive to our intensive care unit with conditions that really should be with the palliative care team because someone hasn't had that discussion with them. We actually monitor that daily. So we can again talk to the doctors and the nurses and say, perhaps that discussion we should, if we haven't had it, needs to happen, and perhaps in future we should be having it earlier.
Right. Let me bring Greg in, because are you in that category of people who finds it hard to give up a patient that you've been struggling to keep alive for perhaps years?
Well, I'm the archetype of it, and I'm always on his KPI list of audit people, because I find it incredibly difficult when you've looked after somebody for a long time with a full throttle save kind of motif, to then, I feel it's a personal failure, or I think I feel it's a personal failure, that I can't do any more. And in fact, oftentimes, the call for palliative care, with the greatest respect, Ralph, actually happens when somebody else covers my patients on the weekend and said, what are you doing? Ring Ralph. And I come back and they've gone to 4B.
Is that because you're God? Because you're sitting next to Helen and she might disagree.
Well, I am, but that's another thing. But it's a very difficult thing. You think it's almost a failure. We've been together 15 years. We've done an operation. We've had a valve. We've done a bypass. We've had a stroke. We've recovered. We've rehabbed. We're walking again. We're doing all that stuff, and then something really bad happens, and and the family gather around, and they switch from full forward. See, in my mind, palliative care, with respect, is not a plateau. Okay, it's not
Can
a
I
place
just
you
say,
go to
I'm a
plateau.
journalist, so I know what it means when you say with respect.
Yeah. That's exactly what I meant.
With respect, Prime Minister.
Yeah.
We'll just get the microphone down to our questioner down the front here, because this is good that someone's getting involved. Hold on.
Just two comments about that. One is, Lewis, with that KPI around the involvement of the palliative care early, is it also a KPI to keep the GP informed, particularly with oncologists? Because so often in the past, at least, we found a patient has gone into an oncological process and we hear nothing for 4 or 5 years. And then all of a sudden there's this cachectic person in front of us who's dying and we know nothing about what's been happening. And that's really poor, particularly when the GP is then the one that might be organising for the patient to die at home or in a hospice or whatever. The other point was, Helen, with the pain's not always physical. One of the things that has really struck me, particularly with the home palliative care, the people who have got unresolved issues, and that might be issues with their children, it might be issues with their parents who are already deceased, but there are some people who, try as you may to help them have a good death, they've got this terrible psychic pain, and sometimes it can be extraordinarily difficult to help them get some kind of resolution and come to some kind of peace. I don't know if you'd like to comment further.
Well, I'll just get Greg to come in on that, and then we'll go to our question from the floor. Go ahead.
Yeah, so where I was that I think we need to learn, we i.e. doctors who were perhaps trained before 1990 when palliative care, 2000 when palliative care existed as a term. Palliative care back in the day, or whatever it used to be called back then, was that very last end-of-life bit. And there was no going home. I remember my grandmother used to say, don't send me to Mount Olivet, which was a hospital here, that's God's waiting room. And God's waiting room, with respect, is kind of that's, I think, what doctors, certainly before the 2000 range, maybe the young doctors think differently, but all of us who trained before that think of the last end-of-life bit, not the plateau bit where you might have a month or a year of plateau. And in fact, I'm not quite sure where I hand off. Where do I stop doing my thing? And then I'll let you do your thing when there's, let's say we both think there's a year to go. I'm not sure where the handoff is.
We do it together. That's the truth. You know, and you keep doing what you do. We're a bolt-on.
Have, though, many people who have, say, a year of life. And how... Just the dovetail, I think, is difficult for us. Just with respect
is it difficult because you personally find it difficult to relinquish?
Yes, indeed.
Oh, so isn't that your problem?
Yes, it is.
So, with respect.
It's specifically our problem. For we doctors who are active care doctors who are in the non-end-of-life phase, it is specifically our problem. And I think it's an image issue within specialties.
In doing that, you're making it the patient's problem, because they then don't have the opportunity to deal with the psychic pain that's been spoken about, those human relationships.
I agree, and I think we do that badly.
Who said we wouldn't find differences of opinion? Lewis.
Look, the hospital and the clinical executive recognise this problem exists with our clinicians, both medical and nursing. We can't provide this assistance to every specialty, but we specifically put in 2 years ago specialist nurse cancer care coordinator. Now the term was done and sold on the basis of assisting patients and families with the coordination of complex care, getting all the people involved and getting on the right path. The actual genesis of was to relieve a lot of our clinicians in that specialty who can't let go by prodding them to let go. So that person's task every day is to speak to those doctors who can't let go to get them to refer. And that's why we saw our KPI go from what was unacceptable to me to virtually none. And that was because we put that resource. Now, we don't have one for Greg yet, so that's next year's budget.
I'm going to need my whole one.
Okay, so I'm going to just pause. We've got I want questions from the floor, and we've got one, so let's go.
Reza Adib, I'm a surgeon at Wesley. In fact, it was a good thing that it got dragged on by a few comments. On an issue of hope and the issue of a nervous patient who just finds out they've got a high PSA, I just want to make a comment to let you know in the last 14 years, the goalposts have also changed, if you agree. So the goalposts have seriously changed. I mean, this time, last night at Wesley, I was operating on a 64-year-old lady who had a nasty cancer in the sigmoid colon, involving a loop of small bowel, involving the bit of a peritoneum around it, tissue around it. She also, I just found out that she had 3 spots in her liver, left and right lobe, and she had a 3-centimeter spot in her lung that was on the CT scan. 14 years ago, this lady was a palliative care, straight to palliative care patient. I took my time and completely resected this tumor last night, fully laparoscopically, with the theme of the day being minimally invasive surgery, because I know once I restage this patient in a few weeks' time, with the PET scan we have at Wesley and all the multidisciplinary team meeting, we're going to tackle the tumor in the liver. We're going to get our lung specialists to tackle the tumor, and this person is going to live for years. And if not, even if they come back with recurrences in the liver, for instance, the goalposts have changed. The goalposts that we have intra-arterial radiotherapy now at Wesley, we got some of the biggest numbers in the world that we presented in the world. So with the same question to you, with hope, these people have now got a new lease on hope and longevity of living. This is not a palliative care to support Greg. Of course, you know.
Well, actually, I'll go back to Ralph to answer this, because at the same time, I know that you're getting increasing demand. I mean, when you started, you had 100 patients a year. Now you've got 700 patients. So people are obviously getting something out of this process. And so, how do you answer these doctors who think, well, actually, we can keep these people alive. We don't need this unit.
And you can. And I guess part of that is that it's because of the way it's being spoken of is I stop and you start. And really, you keep going, I'm an added benefit, or my team's an added benefit. I may not do anything medically. What that person's going to benefit from is spiritual care, they're going to benefit from psychological care, they're going to benefit from practical care in terms of looking, like GPs do, at what's required to make them live safely at home. There's other aspects of what we do other than just get people ready to die. So there's a lot of evidence now to show that early involvement with palliative care actually leads to a longer life. And particularly research is done in the US on lung cancer, that on average people live 3 months longer with a slightly earlier cessation of chemotherapy and an earlier introduction of palliative care. So while that lady is palliative in terms that ultimately she'll die from that cancer, unless another intervening event occurs, it's widely metastasized. It may be cured, but there's a small chance, I guess. But she could live a long time, I agree. So our role there is to just journey. And it's not like we would be there all the time, but at different points in that time frame, we would intersect and maybe assist
You still got the microphone?
with symptoms.
Well, just keep a hold of that microphone. Oh, we've got other hands coming up. This is great. We'll just go back to you quickly there, because I'm just listening to this. Do you think there's actually a way for both of you to work together? That, you know, you might sort of lose this woman for some part of it, but you're not going to be in her life for very often, are you? I mean, what happens when you go away and operate on someone else? Then isn't it a good idea to have a palliative care unit?
Who knows nothing about surgery?
I have been tapped on the shoulder by Ralph a few times in my 11-year career at Wesley that say, Reza, stop. Like, look, this is not, we really have
Has he
that
been
attitude.
right, do you think, when he's done that?
Oh, absolutely. Yeah. Like, we just want exactly what Greg said. Exactly. We just don't want to give in because we just, for God's sake, it's only a small tumor grown on a small bowel that's blocked. If I can just cut this tiny bit, he's going to go for another few months.
Just a little referral.
That's right. It's in the big picture of things.
I never thought I'd be laughing at tumors. There you go.
In a big scheme of things, the goalpost has changed generally when I said, about bigger things. We do much more aggressive liver resection.
Yeah.
Everything we can resect. We do much more aggressive lung resections, the specialists. We do much more aggressive in the... But the reality is there is a place. I have been tapped on the shoulder by Ralph a few times, say, look, it's okay. This guy is not going to make it past this. And yes, it is absolutely, I see what you mean.
And that's an important part of the role. One of the important part of the roles of the pal care doctor is to offer perhaps that big brother tap on the shoulder and say, just let's think about this. And in fact, this is what I sort of half in jest was saying, that on the weekend somebody comes in. But the thing about the doctor on the weekend is they're not in the thick of it. So they come in a detached set of eyes, and the eyes are often common sense and make the call. And in fact, perhaps one of the roles of the nurse, which we have not had access to, is to help bring to front of mind that which is not in the front of mind of the acute care doctor.
Yeah, yes, go ahead, Helen.
I'd just like to say that my guess is that the patient that you operated on yesterday, she may well recover and live for a number of years, but I would almost guarantee that the whole process has raised a whole lot of issues for her about what life is about and about relationships and the meaning of her life and what it is that's important to do with her for the rest of her journey. And so that contact with a palliative care team can give her the chance to work through those things so that however long she's got can be as meaningful for her as it needs to be. And the hope changes to not just the hope of a cure, but the hope of a life well lived for whatever time she has left. And so I think when you work together, you can make that happen for the well-being of the patient.
We've got another question out in the middle, and I suspect it's on this topic, so we can keep going.
It's actually something different.
Oh, okay.
No, at the beginning, talked about multicultural beliefs of opioid use. My name's Danielle. I'm device technologies, but also clinical nurse specialist in anaesthetics and diploma in acute pain management and chronic pain management, which is a new specialty as palliative care. You're saying 14 years. Pain's been about 5 years. Often, before I became a rep, as a nurse, we had to sort of go on a collaborative, I'd say, tangent with palliative care. And this was with the patients, and I guess this comes down to at the mercy of the nurses' multicultural beliefs of their use of opioids on the patients. So we'd have patients rolling in agony, patients who had been suffering with chronic pain issues and come into hospital with with palliative care issues as well, and those nurses not really understanding how to manage.
We're all friends here. Can we say what cultural background would not like to
I was trying
use...
to be ethical.
Sorry?
Okay, I was trying to be ethical, but okay, so Eastern European,
Right.
a lot of the Asian countries, their fear of opioid use, and you would have, and it wasn't language barriers, it was their beliefs on how, a straight Panadol wasn't going to manage someone who'd been on neuropathic pain relief, opioid pain relief.
Aren't they, sorry
dosages.
to interrupt you there, but aren't they under kind of orders for what you give, that's been prescribed by a doctor and when you give it, et cetera, et cetera?
Yes, there are orders and there's scripts, but my question actually was to Deborah, and it was to do about funding for education. So, okay, I'm a nurse that's gone and done a diploma in pain, but you've got the nurses, registered nurses, clinical nurses, and Louis talked about funding as well at the beginning. How much funding do you give to those nurses so those patients aren't at that mercy of have a Panadol. You'll be okay for 4 hours, see how you go. You don't want to have that conversation.
Good point, obviously well made from experience by the sound of it. Deborah.
Yeah, and believe me, it's actually not just a cultural issue. There is many white Anglo nurses who are opioid phobic.
What is that about, by the way?
It usually stems from previous experience, perhaps a bad experience from family member. You've got to remember that the average age of nurses in Australia is up around the 54-year-old. That's the cohort, particularly those that work in aged care. It's that. So if you think about their experience of somebody dying, where it could have been, as a nurse we always have that I've given the last injection fear. I think that's not true, but that's the way that we were trained. I trained in the 1980s, and that's certainly how I was taught, that you don't want to be given the last one, go off shift and hand it over, and somebody else will do it. So I think it's partly our experience in the workforce. So it's not just culturally specific, I think. And I think it is about prescribing rights. I think if you have a GP that prescribes a PRN medication, then I know that on my shift you'll get it, and on the next shift you won't. And so I think it's good prescribing where you actually don't get that choice.
So the PRN means you have to have, someone has to make a judgment
That's
as to
right,
whether
a judgment.
we've reached the point
Yes.
where you need extra medication.
That's right.
Is that right?
So regular prescribing of a patch of whatever, where you don't actually get that choice. A good assessment's been made, and good orders have been provided, and there was always breakthrough orders. But I think you need to take. But it is education. I think it's and you do have to be sensitive to the cultural differences, and now not so much in Brisbane, but in particularly Melbourne, Sydney, you have people from one culture who are the clients, and then you have people from another culture who are the carers. So we may have people from the Philippines caring for people from Sudan. And so very complex to unpack that, and a lot of education required.
Richard wanted to get in there. Go ahead.
Yes, I have seen a change. I have to say it's got a lot better in the last few years. But if I can give an example today, I got a call about a patient who's on a fentanyl patch, which is a continuous release. And I've very much struck that issue, that where I write a PRN order, depending upon who the nurse is, the patient may or may not get it even though they're in pain. So I have, in my prescribing, moved more and more to trying to have it covered properly. But, for example, I got a call about this patient today and was asked to write a PRN order. And what that means for me is I know that I need to go and see that patient tomorrow or Monday and increase their pain relief, because if one of the nurses that I sort of trust with their judgment is calling me and the other ones that I don't trust so much are not, probably this person's got a significant amount of pain that I need to still address. So it's an interesting thing that's happened with that. And the other thing, to go back to something earlier, was around this whole opioid averse culture with nurses. Years ago I was talking about a 55-year-old Catholic priest who went into a nursing home, and he had metastatic prostate cancer and terrible pain in his bones. And he was beside himself, absolutely distraught. And I remember there were about 5 of the senior nurses, and the average age of nurses now in aged care is about 58. And there were 5 of these senior nurses who had all come to the conclusion that he was an attention-seeking, badly behaved little old priest. And
there's so many.
Yes. And I increased his morphine through a pump to a ridiculous level. I think it was something like 180 milligrams an hour. But this was like 15 years ago. And the nursing home was freaking out. They really felt that the police would come any time and the place would be shut down. But when I got him up to that level, he went from being this person who was screaming and crying to someone who suddenly was peaceful. And he lived for another 6 months. And for 5 months of that, he got around in an electric wheelchair and celebrated Mass with the other residents in this Catholic nursing home. So for 5 months of his life, he got an added real meaning for his life, real value for his life, because as a priest, celebrating Mass was his core identity, and that was restored to him, rather than being someone who was out of control, just screaming in pain.
Yeah, Ralph, that brings to right back to the point I made when I was talking earlier about the greatest fear I think that most people have is that they will die in terrible agony. And so what's available to you? What are the range? I mean, is it truly possible? I mean, you don't, for example, have fentanyl lozenges at this point.
No, we have lozenges.
Okay, the lollipops.
We don't have the little sort of button ones you stick on someone's gum.
Okay,
which is very nifty.
What is available, and how much has that changed in, let's say, the past 20 years?
Oh, it's changed a great deal. I guess I feel a little what's we're not talking about is what everyone does in general practice, because a lot of this is bread and butter, good general practice. And what I've got available is largely available to GPs who understand the process and who can prescribe the same medication. And in Australia, we're spoiled. We've got bucket loads of stuff, really, and at least 7 different narcotics that we can use. And you've got to keep a secret one. You know, the infectious diseases guys have secret antibiotics. The cardiologists have sneaky little procedures. If you haven't got that, you haven't got a specialty, you know. and that'd be terrible. So I've got to have the occasional special drug.
What is What is it?
He's
I
not
mean,
gonna
what?
tell you.
It's not Kentucky Fried Chicken
No,
here, mate.
I'd have to euthanize you, I'm sorry. Strangely enough, one of my secret special drugs is methadone. Methadone's fabulous, and it's making a big resurgence as a pain-relieving agent. I think it's really, really useful. So, but it's a very tricky drug to manage, and so people need to be an inpatient to really be safely prescribed it. But there's a huge pile of stuff, and it's not just narcotics. I could talk too much. About 90...
But I think people want to know. See,
Yeah.
I personally am very interested to know that if you get to some point where you're in screaming agony like that priest, but this is the modern world, so that was a long time ago, right?
Yep.
So what can you actually do what would you do for him, for example, or someone like that in that kind of agony?
Yeah. I guess the general principle is you treat pain as an emergency, just like you treat heart attack or acute appendicitis. Then pain needs to be treated in the same manner. So when you listen to the story, you understand the pathology and you can make an assessment as to the nature of the pain and what agent is likely to be most helpful. And then I think you administer with great ferocity. You really apply yourself until either you produce intolerable side effects or you produce pain relief. And the bulk of time you produce pain relief first. If you produce intolerable side effects, you stop, you backtrack, you change to a different agent, and you move forward again.
Have you had instances, such as we heard earlier, of people who were, looked like they were screaming for an early death, who get a period, perhaps however long it is, of relief?
Yep, every day I would say that people's lives are changed by the nature of pain relief. And the shame of that sometimes is that pain relief's been available for months and they haven't had the right person.
Well, that brings us to
involved.
the question from the floor, actually, and I did want to get you to address that, because is there a structural problem within hospitals where people are not following orders on their own reconnaissance, as it were?
In part, partly it's really education. I think it's the fear as a society we have that narcotics are bad. I love them, but that's another issue. So it's that fear that stops people, I think, and the sense that, yes, I'm the one with the syringe and I gave the last needle and that patient died. And there is sometimes just people can't empathise, and we've all met people who just can't see the suffering in front of them. And sometimes it's a lack of education. They say, what are you whinging about? You've got a pain patch on or you've got a pain pump running. You can't have any pain. I'm going to wash the patient in the next room. You be quiet for a while. And it's really education more than anything else. So we leave those orders, and I'm a very generous man when it comes to how much medicine people can have. But I've been astounded even in the hospital. Sometimes you'll come back to a unit that commonly doesn't deal with pain, and you'll say, well, this person's in clear distress. What's going on? They say, well, you put the pump on. I don't need to do anything. So sometimes
I mentioned to you on the phone, but the cartoonist Bill Leake had an accident where he fell on his head and he was in a lot of pain, and fentanyl patches helped him out. And after he wasn't doing his cartooning, I saw him walking along a beach with his dog and he looked fine. I said, why do you look so good? You can't work. And he said, well, I've got the fentanyl patch on. And he said, do you think I'm doing well? You should see my mate who's got terminal liver cancer. He's got so many they look like a wetsuit. I know that's a joke, but is it actually possible to keep
make
people...
a wetsuit out of fentanyl patches? Yeah, I'm wearing one now.
I thought you were quite high functioning for whatever you are.
You can relieve probably 97% of people and their pain. And there's about 3% where it's a really, really, really difficult struggle. There is no doubt about that. And I think there are really high-tech procedures available, right down to David targeting the anterior cingulate gyrus, I think is the... If you burn it out, you can sever the perception between pain and affect.
David, I've heard you referred to as a spot welder, is that true?
That's right. There are various things about radiation that... people are fearful of it just as the way they're fearful of morphine. Of course, we're very comfortable. I'm as comfortable with it as Ralph is in his area. But I think, again,
we can prove that by turning off the lights.
Yes. I think
he's the only one who'll glow in the dark.
in essence, I
Sorry.
think we should know.
That's
we
one of
use
those ironic statements, really.
Well, I think we should reassure you, Tony, that in fact the people will not be left screaming in agonising pain. And as Rob said, it's 97%. This can happen very quickly. And radiation's one of those modalities, and particularly so for that last 3% where spot welding bone pains particularly is very helpful. There are techniques to spot weld things inside the brain, burn out the pain centres and so on. We don't. They're available, but we seldom have to use it. So
Listening to this high level and very sophisticated, although we're having a bit of a joke with it, very sophisticated argument about what's available, it does seem to change the underpinnings of the euthanasia argument. What do you think?
Yes, I believe so. I think, again, I'm not comfortable with that. And again, as you look at people who come into our centre, we've got sign up the cancer centre and people walk under it. The people with skin cancer universally think they're going to be dead any moment. And those who've got stage 4 everything cancer are really completely confident they're going to live forever. So the matching of things is quite difficult. And I think having clinicians who deal with a product called communication is again the key to this. So communication all along the line is crucial. We've found that this notion of hope, giving people who don't have much to do and feel hopeless and despairing and are unable to move on at all, and see no purpose for life, they would rather die. You can actually work on this concept somewhat and improve, the hope. Even a small thing like hope you'll get a cup of tea, and a tiny thing, and the hope can invest that final thing. And I don't find the need for euthanasia. I think.
Just on that hope thing and how you persuade people, from your perspective as an oncologist, yes, do you need the palliative care unit to achieve that? Is that where the hope is engendered?
Well, it's engendered. I think everyone can engender hope. I think it's within the capacity of every clinician, and I think part of what Greg would do, even if he's doing the palliative care process to the very end, he has a therapeutic relationship with them that's really very valuable. He has a knowledge of that patient, and the patient has a confidence in him, and that relationship engenders hope in its own right.
I guess the point I'm making is you don't really have the time, do you? I mean, you've got to go and spot weld the next victim. Victim.
We too link with the palliative care team, so we're very much linked into that process, and it's much more seamless because that's our area of endeavour, and we would at times tend to refer people very early. So perhaps at the time, if they're coming from anywhere at the time of their first metastasis, it's from our centre, I suggest.
That was sort of my point. And I didn't mean victim. I really didn't. John Yaxley has a question, and it takes us to another area which we need to be... Oh, we've got a couple of hands up there as well. Oh, is that John down there? Yes, John. John, we'll get you a microphone. It's right over there. And... Oh, you got another question? Okay, we'll come straight to you after John. We'll hear John and then we'll come back to you.
Thanks very much. I was just, I suppose, changing tack a little bit. My grandfather died, my grandfather-in-law died 12 weeks after a diagnosis of an inoperable terminal illness of pancreatic cancer. He died at home, so his whole care was at home. So where do we take where we are at the moment with a lot of palliative care in hospital to a more community-based service with respect to the social and the economic burden of taking it down that community-based line, and where does the private-public interact with that? And if I can, through Tony, where is there a religious and sort of spirituality link in with that?
We'll start with Deborah on that. How do you actually do all of this, the stuff that we're talking about, out in the community, and indeed out in nursing homes? Because nursing homes don't have palliative care units.
No, they don't, and they probably don't really need them. They just need good, well-educated staff. I think care at the home, I think, is done quite successfully for a number of people. About 25% of people die at home receiving palliative care, and so I think when you're talking about shifting the cost, you're looking at the cost shift to the informal care sector. So family giving up work. They're sharing the cost more than the palliative care service. I mean, to have somebody to die at home, my brother-in-law died at home. He was only young, and I took time off work to help my family provide that care. So I guess the cost shifted in that respect to me to some degree. My sister gave up work altogether to provide that care. So
how did you do it? How did that work? I mean, I know...
To provide the care?
Well, yeah, I mean, exactly. I guess you had training, so that obviously helped enormously.
Yeah, but many people don't.
Yeah, that's what I'm saying.
We had early referral from the oncologists to the palliative care service. And in the early days, in actual fact, as Ralph has said, after the first visit from the palliative care team, it was ring us when you need us. He lived for 12 months after his initial diagnosis, which was always going to be palliative, not curable cancer. But we really didn't use a lot of the palliative care service probably until the last month, maybe. And certainly in those final days, we had a nurse coming in every day to check, make sure things were all right. We had access to the doctor.
I suppose in a way you were providing palliative care yourself.
Absolutely, and that's what happens. That's how it happens in the community. Is that, and I think we have to think back to how did it used to happen, and we have really medicalised dying, like we have medicalised childbirth to many in many ways, and so I think there is.
It'd be a shame not to medicalise it in this sense, though.
Absolutely.
From what we were hearing about,
you need the medical component of it.
Exactly.
You need that skill, but there's, we call palliative care low tech, high touch, and who better to provide that at home than a family member? But only if you have family to do that. And of course, there is many people who don't. And so, what happens to those people? They come into hospital, or they go into an aged care facility if they're old enough. So I think the economic argument is, it's actually cheaper to provide palliative care, a community palliative care service at home. It's predominantly a nursing service. Nurses are a lot cheaper than doctors, Ralph. And as I say, you can be cheap. And so I think it's a model that we need to seriously better fund in this country. I think there's an argument that it's a bit like if you build them, they will come. If you start building more hospices or start putting more beds in your public hospitals, then more people will die there. If you fund community care to the appropriate level, where you have 24-hour access and you have good support, then people will die in the community.
Yeah, that's kind of philosophical argument you're making there. But I gather you're not against palliative care units, though.
Oh no, not at all.
You need both.
Absolutely, you need both, and people do come in and out of those units, and they do it for very good reasons. But there is a lot of the care, particularly in the cancer world, where people are fairly mobile. My brother-in-law was mobile until 2 days before he died, so it made it very easy to care for him at home because you're still walking around. That doesn't happen for everybody. So
let me go to Richard, because GPs are fundamental to community care. You'd have to imagine. Are they available though these days? Some might be, some are, but in general, I know that wanting to get a doctor at home from time to time has been very difficult. And I wonder how that would be if we had a terminally ill person in the house.
That's one of the challenges with how the system is, and it's particularly in terms of incentivising GPs to do it. At the end of the day, general practice is small business, and as much as people like me are very charitable and altruistic, we have businesses to run. And if at the end of the day the financial model is such that we can't afford to do it because our business will close down, then that makes it a very difficult proposition. So the basic thing there is that currently the way palliative care is funded for general practice, and for that matter even domiciliary nursing services and others to go in, it's a very poor financial model. But having said that, I still do it, and a number of other GPs do. But if the system was to change...
You find it personally rewarding?
Immensely rewarding.
I mean, a lot of people might want to stray away from someone who's dying, but...
Yeah, no, I feel really privileged to help people and their families have the experience of a good death rather than a bad death. And general practitioners like myself that work very closely with domiciliary groups like Karuna, Blue Care and other domiciliary nursing agencies, there's a wonderful rapport there. And even where people don't have families, groups like Karuna have volunteers that go in, and they've got a very rich spiritual base to it that's not inflicting any kind of religiosity, but the spiritual base is one of a very deep-rooted respect and a great sense of dignity for the person that's going through the dying process. And those people are assisted and supported rather than being told to do this or that. They're not directed in any way, they're supported in their own journey. And the costing around it is an interesting thing. Someone who's dying in an intensive care bed is $4,000 a day. Someone who is dying in an ordinary acute hospital bed, it's $1,100 a day. If it's in an aged care facility, it's $200 a day. If it's in a palliative care hospice, it's $600 a day, or if it's in a facility in a hospital, it's $950 a day. If it's in the home, no one really knows, because as you said, people give up their work, but people often want to do that. They want to do something special for that person that they love.
So you're saying it's cost effective, basically, to support those people to do that?
Yeah, there are some figures that suggest that it's about $90 a day, where compared to intensive care, where it's $4,000 a day. And it comes back to something I wanted to say a bit earlier, and that's around the notion of informed consent and futile treatment, and engaging in people a process where they can see, yes, we're going to be heroic for a while, but there will come a day probably where we need to talk about this treatment now becoming futile, and we really need to be looking at your dignity, your comfort, and your quality of life in those last few months or year or whatever, because some people get so caught up in that whole curative kind of treatment mentality that they go through all sorts of degradation and suffering to try and get this curative result when it's clear that it's not going to happen anymore. And in that process, they lose an opportunity to have valuable time with their family and their friends, and they lose that opportunity to have some really good quality life in those last days, weeks, months.
Yeah, I'll just bring Greg in here and then I'll go to Helen. Greg, futile treatment, have you been guilty of it?
I think we try very hard to find the trigger point where something becomes futile, and in fact, just like you made the point about when you say to the Prime Minister with respect, I find when you say the word dignity, as soon as I use the word dignity, that means we want them to have dignity and comfort and quality of life. That means in my mind, I've made the switch from full forward to we've gone past the futile point. And I think we do recognise that. I think that we're not that bad at recognise futility. And in fact, 2 days ago I made a decision not to bypass somebody elderly because of futility, who subsequently went to heaven fairly quickly. And my daughter, who's a medical student, said, how can you make that decision but for this person? And I said, well, I didn't make the decision, I made the judgment to not offer a futile treatment. And I think that's the role of the senior clinician who's got mileage. There's no book to look this up. There's no ethics professor who could tell you the right answer. This is a judgment based on the person and hopefully a breadth of experience.
And Helen, we were talking about community care there and the nature of spirituality, how you actually deal with people in their homes when they're dying. Have you had to do that yourself? And by the way, what happens in remote communities? What happens in regional communities? What happens when you're further and further away from the resources?
Well, spirituality and spiritual care isn't all about paid clergy or paid chaplains going in to offer that, and people certainly get offered good spiritual care from their family, from their friends, and from people within their community network. I'd just like to make the point that not everybody actually wants to die at home. A lot of people do, but not everybody can offer it. If the elderly wife or husband isn't well enough to be able to care for them, then, and not everybody wants to remember the front room as the place where Dad died. So, and sometimes families are divided. So I think it's never an either or, it's a both and good palliative care units can help people to die a good death at home. And the spiritual care and the religiosity, if they've been a religious person, they'll obviously often be linked into their own faith network, and people are sometimes more comfortable visiting someone at home than in a hospice or an aged care home where they think it maybe is catching. They might get old while they're in there. But there are also community chaplains, and Blue Care has people who go into the community and work with the community nurses, the palliative care nurses. So there are options to provide that sort of care.
And does this process, we're talking about the community, and by and large we think of the community being people around cities clustered around areas where all the resources are. Take community beyond that to regional areas, to country towns, remote communities, that sort of stuff. What's the exponential difficulty there?
There are, and again, Blue Care offers pastoral care to right round Queensland. Anywhere where there is a Blue Care service, which is most of Queensland, there is a chaplain available to them. But it may well mean that they fly in and fly out, or drive in and drive out. And I was talking to some chaplains recently who'd been way out west, and they said that they find that country people will just get straight to the heart of their problem. No mucking around with polite conversation. They know that the chaplain's only there for a brief time, and these are the things that they want to talk about. And they may be religious, but they may be about life and meaning and what's it all about.
I know what you mean there. I always like that story of the bloke who had a heart problem, and he used to go out and hang onto the electric fence every day. Like this, and I'm right for another day. Lewis?
I wanted to make two comments. One was just an aspect of training. The training is very difficult to resource in any of the environments, community in the hospital. I just wanted to give a shout out to Ralph and his team. They've been training palliative care registrars, general practitioners and interns now, and medical students in his unit. So there's a whole group of graduates, or recent graduates or new graduates, who will be at least exposed to palliative medicine, which I think is a major benefit. But I remain in the deepest respect with the community services, and I have grave concerns that under the current financial restraints that we have both at the state and federal level, that we can possibly cope with increasing community demand of looking after patients at home. We have had significant cuts in community-based healthcare in this state, and we've got a lot of pressure now where the state will have to look at other funding for its own hospital care and community care. That's changed since Tuesday night. And as a result of that, that also impacts on general practitioners. At Christmas, I mean, you've got to look at the thing, think of a system. A system of community-based care has to work on Tuesday morning and it has to work on Christmas Eve. And it has to work the whole time or it fails, in my opinion. If patients, families resort to having to get their iPhone, press the recorder and put it up against their loved one who is gurgling to death at a nursing home in this city, and then send it by text to my wife as a GP so she can hear it and then intervene. And that's what happened this last Christmas, because that's the type of service that we got left.
That's
after
telemedicine, isn't it?
And then get up to that nursing home and change what the patient needed. There's no resourcing paying for that. There's no funding that currently pay for that. The patient doesn't have another $7 to hand over at that time. I'm not quite sure that's going to work. I think that is critically going to be facing us. We've looked hard in healthcare. We're at 9.4% of GDP. We've often been told how we're much less than the United States with better outcomes. We are not as high as other countries. The reality is we now have additional pressure to find funds for hospital, and this is public hospital care and community care, which things such as palliative care are not anywhere near on the horizon. Watch the news each night, that now it's an hour news. You will watch it at the halfway mark, virtually every night, there's story on research, if you're just watching it at the moment. And that research is always about a treatment for cancer or another life-saving thing. Nothing about a research for palliative care. There's a new drug for cardiology, but you don't get the same sort of promotion of a drug for palliative care or some type of treatment plans for palliative care. And I think we're still a way away from that adequate resourcing. And forget about Wesley and the private hospitals. We can battle with the health funds every day as we do. I'm talking about the guys on the ground here who have to pack up that bag on Christmas Eve and say, I'm going to go and look after that patient, whether it's the community nurses. That's a real challenge that hasn't gone away. And we are treating more patients. Since I've been at Wesley 10 years, we're definitely treating more patients. Rez is right. And therefore, we have more people who need palliative care, not less. We've got more people who need to have combined care, not less. We have more people with complex symptom control than we've ever had because we are doing more care to them. And I think our challenge in this area is it's uncomfortable. It remains an uncomfortable area for people to deal with. There's plenty of money. If you've got breast cancer, you can go and do a walk for people with breast cancer. But wait till they get metastatic disease and see how many people go out to walk for them. It's a very different picture. End of life, dying, terminal phase. Difficult for the community, difficult for clinicians.
That's why we're here talking about it tonight, and thank you for that. We had a question down the front, I think. Did you want to ask a question? Yeah. You got a microphone? Go ahead.
I do. I think tonight we've been talking about dignity of death. And there's two issues. You've been talking about pain, and there's the other issue of anxiety. And I'd just like to know from the panel, we've been talking a lot about opioids and what you can do with them and how you can administer them and whether you do or you don't, because in my experience, unfortunately, the nurses think that if you give patients opioids, you can addict them to it. Big problem. I don't know in my 41 years of medicine that anybody has become addicted to morphine if they've got pain. They'll certainly become addicted to it if they don't have pain. But the issue of anxiety is another thing. Now, David Schlecht, John Bashford, and Murray Burke, who are here tonight, have all worked with me with my patients, and I've worked in oncology for many years. I think we actually did a great job, and it preceded Ralph, who was one of my residents.
I wasn't damaged.
No.
But he went into palliative care.
Indeed, it doesn't surprise me, Ralph, what you've done because of your nature, so kind and caring to his patients. But I think we worked as a team, and I think palliative care is great, but I think the primary physician, the GP, is still paramount. But the issue of anxiety is another thing which comes into your area, Helen, and Helen and I sit on the Uniting Care Human Research Ethics Committee. And it's something that I don't think is very well dealt with.
Well, let's throw the issue of anxiety to the panel, and I'll start with Ralph, and then I'll go to Helen. I'll hear from both of them. That is obviously a huge issue. And in fact, once again, all in the literature. It's about, it's built into the literature as to why palliative care, what it needs to work on.
I guess a large part of it comes down to the same product that David was selling, and that's communication. I think you need to take time, and that's a pressure on general practice as well as it is in hospital medicine, to actually stop and be with that person such that they recognise you're attending to them and you're really listening to what they're telling you. And sometimes anxiety will go away in that setting where people say, you're listening to me and you're taking on board my concerns and my worries. And sometimes that's all that's required. Mind you, there's a continuing relationship and things have to evolve. So in part, I think it's paying attention and communicating. And I think having an understanding of what lies beneath the anxiety. And sometimes that's about fear, sometimes it's about money, sometimes it's about not being able to educate your children, sometimes it's about loss of dignity. And I think that's the beauty in hospital, the luxury of a multidisciplinary team, because we've got very experienced nurses as such who do a lot of that work quietly while they're helping the patient have a shower, or while they're making the bed or doing other nursing activities with them. They can do a lot to resolve some of those issues. But also experienced counsellors and chaplains make big inroads into that. And I think general practitioners are particularly important.
Is there a tendency to, well, once again, in the literature says, anxiety, well, yes, counselling, but these series of drugs as well. So again, is there a tendency to fall back on medications to solve that problem?
Yeah, drugs are great, full stop. But in this particular, you give people anti-anxiety drugs, it's good because they stop talking. You just make them go to sleep. No, I'm being a little cynical. Yeah, there's a place, there is. The problem with a lot of the drugs that resolve anxiety is that with time you become tolerant to them, the number you need to take goes up, the side effect rise while the benefit probably stays the same. So you've got to use that judiciously. The danger always is, just like people say, well, I can't sleep. You say, well, here's a sleeping tablet. But if you said, so what's happening in the long dark tea time of your soul at 2 a.m, It's fretting for their wife. It's worrying about financial stability of their family. And a sleeping tablet's not the answer. So it's giving time and conversation, I think, more than anything, and then applying it with expert help.
Helen?
Yeah, I totally agree. I certainly went into healthcare thinking that drugs were prescribed far too often for anxiety and depression, and then saw what a difference that they can make. So sometimes a pill can actually give people the space to step back a bit and think about the things that they are anxious about and see them dealt with. And people are anxious about a whole load of things. One of the most useful people for treating anxiety in the Wesley is a financial counsellor, because people are very anxious about where the money is going to come for their treatment, for their family's future, and all of those things. And so to have... And another person in the whole continuum who can be really useful in treating anxiety is the cleaner, who just goes in and has a chat with people about what's happening in the day and about kids, and their kids went through the same thing when they were being treated. So anxiety is a huge, huge, huge spectrum, and having people around who have the time to sit and listen is really key, and I think that's a luxury that nurses don't always have in aged care, don't always have in acute care, or in the community. And I think community involvement, volunteers and people who have the time to sit are just invaluable.
We are nearly out of time, as a matter of fact, but what I wanted to do, I wanted to hear from at least a range of our panellists, and others can have their own opinions on this, why they actually got involved in this area in the first place. Lewis made the point to me when I spoke to him the first time about this, it is very unsexy and not particularly financially rewarding part of the medical industry. Lewis, I'll start with you actually. Why do you think you feel so passionately about it?
Well, I think I'm very lucky to have become a general practitioner first before I went into the hospital administration. I work with at a practice where providing palliative care is fundamental, and in fact our practice that came together was because one of the practitioners, Richard Kidd, looked after my mother-in-law through her palliative care terminal phase. I see my spouse providing superb palliative care at home for, in fact, medical colleagues here, family members who've died at home. And I'm extraordinarily proud to be at a hospital that puts palliative medicine where it has, even though we have to, as I said, struggle week on week with it with regards to the finances, and work with people who accept that at a management level because they're part of a not-for-profit church group. And in that environment, it's actually easy to be passionate. Now, it's actually very hard to be Ralph's boss because he's always agitating for something to do with his unit, money, more things. He comes down and he's so nice and charming that when he comes to the office, you actually feel like you should give it to him. And then he leaves and you realise you just has no job, and he's got another half a nurse counsellor. But it's when you have that sort of people around all the time. And then, to be very blunt, my patients have been in his unit. They've been in our hospital. And the care they've been provided by the team, you just then stand back and go, well, we're very lucky. It might be that it's a first world benefit. It might be a private hospital benefit. It might be a Brisbane benefit. But at least it's where I am, so that's why I'm happy.
I'll go with Richard next, since you were mentioned in that answer.
It's a really hard question to answer in some ways. I think it started with, at the age of 7, reading about Albert Schweitzer and the stuff that he did. And I was very lucky that as a junior doctor in Auckland, I at one point worked on an acute geriatric ward that actually took all the patients straight in for admission. And that geriatrician was a truly inspiring person, and I had an interest in mental health and other things. And I went and worked as a volunteer in Papua New Guinea, where I saw people die with no support of any kind. And we're not just talking about older people, we're talking about women in obstructed childbirth and things. And I saw bad deaths. And when I came to Australia, I saw a need and there was an opportunity to do stuff, and I did.
Deborah?
By chance, to some degree. I had worked for about 15 years in a variety of aged care settings, and my last aged care stint was in a public hospital in a geriatric unit. And really for that 15 years, I don't think we had a particularly good experience of older people dying, because it was many years ago.
Many of those people with dementia, presumably.
Yeah,
Something we
many
didn't
with-
get to talk about
yes,
tonight.
there's many with dementia or just, multiple organ failure, just, old, failing, not recognised within the public hospital system, jumping on too many old people's chests, completely futile in those days and having very few success rates, and having the opportunity to go and work at the Doorhouse Hospice with Professor Ian Maddox, who many people would know, who's one of the fathers of the modern palliative care movement in Australia, and I thought, well, maybe that's an interesting to take that aged care experience and see what palliative care has to offer, and so I just took a 12-month leave without pay from the hospital just to try it out, thinking that it would actually be a very sad place to work. Aged care is sad enough to some degree, but I thought, boy, palliative care is going to be really sad, but it's not. It was actually the most fantastic experience.
Yeah, it's what I've said at the beginning. It's sort of how I kind of approached this subject without knowing about it, and the more you know about it,
and the people are fantastic.
It's actually quite inspiring in some ways. Ralph, what's your reasons?
So my career was in general practice, some of you all know that, and really it stemmed from caring for an 8-year-old child with leukemia and seeing her die at home in the 1980s, and I think as a community general practice, I think along with the local nurses, we didn't do a bad job, but it left me thinking, surely we can do this better, and that set me on a path of educating myself, really, I suppose. My heart lay in general practice, and it probably still does, and I think one of the things I'd like to say is that we cut you out a lot of the circuit. Like you said, you can go years and miss your patient, and then we give them back to you in a parlour state and say, hey, all yours. And I'm very keen to not keep patients. They belong in the community and they belong in the care of good general practitioners, and I would rather our role, this is just an aside, was advisory and supportive, and that the work is really done in the community, and it is intensely satisfying. And that's the thing, the hook that got me in general practice was you had to be a good diagnostician and a good physician, you had to be a good pharmacologist, you had to be a good psychologist, you had to be willing to make some personal sacrifice to do it, but to care for a family and deliver their children and to see people through to the end of life, I think is one of the really great attractions of general practice, and it's sad that it's being chewed away. And in the end, for me, to continue that experience, I moved from general practice to specialty practice because I feel GPs are being undervalued and bits are being sliced off every day from what you can do. And so I've kept my bit and taken it with me into the hospital, but I don't want to hold it from others. I think it's a really rewarding, intensely satisfying part of medicine, except when it goes wrong, and then it's really, really crap.
Helen, why did you get involved in this field? And I know from talking to you, it's not simply just to gather souls.
No, that's absolutely the last thing. But I can't talk about it without using religious language. And I guess it was the experience of working in aged care and sitting with people as they died and seeing the love and the care of their families or the anxieties, and just having this real sense that this was a very sacred time when this world and the next, however we might conceive of it, come very close. And then seeing the care of the staff in aged care, and I see it in acute care as well, and in the community care, and a real sense that this is the hands of God in offering care to people at this really vulnerable time of their lives. And so it just has, that has become a particular area of interest to me in supporting those staff who don't go through this unscathed either, that constant confrontation with death and suffering, but just a real sense that the beginning and ends of life are particularly sacred times.
Terence, well, you can applaud that if you like, because that was such a lovely way of putting it. Terence, as the bean counter, as this person who actually has to sit above all of this and decide whether to dispense resources to it, you have done that. In fact, generally speaking, it's been done. But what are you kind of moved in a way by what motivates these people?
Short answer is yes. I don't think anybody works in medicine and clinical care without being so. My wife and I come from a background of very close-knit families. As an aside, we've nursed 4 of our family to death at home. And so palliative care for us is, you know, it is those last few days, but it's also the last few years. And so there's this continuum through it.
Which is in a way a good argument for the rest of the community, isn't it? Everybody has to go through this.
Absolutely.
Every family understands it.
Absolutely. And for the last 7 years, I've managed a hospital at what is euphemistically known as God's Waiting Room at Buderim. And when I got there, there was some palliative care. I was pleased to be able to implement, and in my bio that Christian read out before, it was about systems, and it was about how to make things work efficiently. And so that little hospital now has 6 palliative beds. They're not licensed beds. We lose lots of money. The issue about skills and cultural sensitivity, you manage that as an administrator by making sure there is training, as Lewis said, that there is people with knowledge, that those staff are rostered, rotated, trained, developed, supported over and over and over and over again. And that just comes back, I think, to why we entered into clinical care. So for me, it's about that.
And Greg, not uniquely on the panel, because we had people from the audience saying the same things. You know, had some doubts. I think you still have doubts as to when the right point is to hand over, etc. Listening to the motivations and listening to the rationale of the people who are involved in it, are you changing your mind? Are you open to rethinking that?
Well, I've evolved a lot in the last 5 years, I think, and I have enormous respect for our unit and the care that they've given my end-of-life patients. What I really haven't done is engaged in the plateau phase before end-of-life. I think this is a learning thing for the acute care physicians, surgeons who haven't grown up with this. And I think, but through excellent example and leading by example, Ralph and his team have taught us a place where we can dovetail in from acute care to plateau care to end-of-life care. And that's the plateau that I think we have to learn about from our side.
And David, finally.
Thank you. People ask, don't you get depressed with your work with cancer and so on? But in fact, as a junior doctor, I always felt very comfortable working in cancer wards and in radiation areas where no one else did. And so that was handy. I also like being a clinician. That's what I do. And I work, you know, I like my job as in that capacity and dealing with people. I like people. I like being with them. I like working with teams. And I think from an early stage, I could see there was a great need for further technical development in radiotherapy and cancer treatment. So I was attracted to the technology side of it. But and that's come, and that's what I do. But in fact, in many ways, I'm a clinician. I like that.
I think unfortunately, we're out of time. But I think it's been a really interesting, as I sort of predicted it would be, a really passionate discussion and a fascinating one. I hope you all enjoyed it. Please thank our panel.
Well, ladies and gentlemen, and Tony particularly, on behalf of Uniting Care Health, the Wesley Hospital and St Andrews Hospital, we'd like to thank you for being the compere again this year. I'd actually like to personally thank you because I have my mother who lives in a nursing home. She has terminal Parkinson's disease, and one of the great pleasures that she has each week is turning on the ABC, watching Q&A, and everything else ABC, and over the years having sort of watched, I guess, the late Andrew Olley and Paul Lynham, yourself, Kerry O'Brien, and other people on the ABC. She very much enjoys that, and also, you know, having that cup of tea and that biscuit late at night time. The only flip side for me is on the weekends when I go to visit, I'm usually asked about the latest episode of Q&A or Late Line, and invariably I've actually missed it, and so I'm berated for a little while about not paying enough attention to the discourse and communication of public life, I guess, and what's happening in that space. But she certainly enjoys that, and certainly tonight has been very enjoyable, and I think it's been very informative, and certainly that broad brush conversation that we've had not only about clinical care in general practice and the hospital-based setting, but also the ethical and other dimensions which come into looking into palliative care has been critically important. So as a token of our appreciation, Tony, we'd like to present you with a gift.
very kind. Thank you very much.
Thanks.
We'd also like to thank our panellists this evening who've been here and contributing to this event, and also having their specific points of input into this. So we've got a gift for each of the panellists, and Vicky's going to present those. So if we could thank the panellists. And while Vicky's giving out those gifts, we'd also like to acknowledge our sponsors again. Our gold sponsor for this evening was Medtronic. Our silver sponsors, our sponsor Device Technologies, and our bronze sponsors QML Pathology and Queensland Diagnostic Imaging. Without their continued support, we wouldn't be able to have an event like this evening. So if we could put our hands together for those sponsors. So look, on behalf of Uniting Care Health again, thank you for coming along this evening. We hope this has been beneficial and very informative. We'd now like to welcome you to join us for a drink, to catch up with friends and colleagues, and also for those who'd like to have a photo with Tony Jones. I did that last time and my mother was very happy to see that, so I'm sure Tony will be willing to do that again for those who would like to do that. Okay, thank you very much.